Good evening. Welcome to Health Plus Weekly. I'm your host, Pete Koheno. With me, per usual, is Dr. John Podkowa today, and we actually have a special guest, Dr. Holly Alexandre, who is an addiction specialist here at Southcoast Health. She is here to talk with us about addiction, but more specifically, opioid addiction, which obviously is a huge issue right now, not just in this community, but across the nation. So welcome, Dr. Podkowa.
Thanks, Pete. Nice to see you.
You too. And Dr. Alexandre.
Thank you. Hi.
So I'll start off by just kind of segueing into addiction. Can you talk a little bit about just what you do, Dr. Alexandre, specifically with addiction, and how that might be different from, any other doctor that someone might see?
Sure. So just to clarify, I am a primary care physician. I'm a family physician, and I take care of people with all kinds of primary care problems, from routine physicals, sick visits, from birth until the end of life. And specifically, though, I have a segment of my patient population which come to me for treatment for addiction. Many for opioid addiction, also for alcohol use disorder. And what I do in my office, if they have a relationship already firmly with their primary care doctor, then they can just see me in consultation for treatment. If they don't have a primary care doctor, and many patients struggling with addiction disorders have let their primary care lapse, then I also provide them with primary care. So my office is different from other places because we integrate primary care with addiction medicine.
Excellent. And I forgot to mention in the beginning, please send your questions in. As always, we want this to be a show that you're heavily involved with and have an opportunity to ask the questions that you might not get to ask your doctor normally. Josh will have up on the screen shortly a phone number for you to text your questions to if you'd like to do so anonymously. But if you're comfortable asking a question, you can do so in the comments section below. We're trying something new with format this week. We are going to try to stick to the topic of addiction for the first half, 3/4 of the show, and then at the end of the show, as we normally do, we will take your general questions for Dr. Podkowa, and Dr. Alexandre will be able to answer those as well, since she's a primary care doctor as well. So on the topic of addiction, let's just start by getting into opioids. And why has opioid addiction become such a big issue in this country?
So if you were to look at this historically within our country, first of all, you need to understand that the United States writes more prescriptions for opioid pain medicines, exponentially more than any other country in the world. What happened is, prior to the 1980s or early 1990s, very few prescriptions for chronic opioids were written by doctors in the U.S. It was mostly patients who were getting end-of-life care or post-operative surgical patients for a short term only. And then what happened is there was this big push for doctors, and it really kind of came from, in some parts, government regulatory agencies, to make sure that doctors were treating pain. And pain became what they call the fifth vital sign. And so when anyone had any interaction with a medical facility or with a physician or a provider, they got asked to rate their pain, even if they weren't there for pain. And this became a quality measure for doctors and for healthcare facilities as well. Were you treating enough pain? And what we saw was this exponential increase in the amount of opioids that were written. At the same time, pharmaceutical agencies were coming out with long-acting pain medications such as OxyContin, and those were being marketed and really pushed on to doctors as a safe way to treat your patient's pain. The data showing the effects, the dependency and tolerance and overdose risks were really not being shared with doctors. There's been a lot in the news about what happened at that time. So we had this large amount of pain medications that were being prescribed opioids. There's always been, throughout this, a small amount of heroin use that has always gone on with a small percent of the population. But now what we had happening were patients who were becoming tolerant and dependent and forming opioid use disorders on these prescribed medications. And their habits were getting out of control, and then what they were doing is turning to street drugs, either buying illicit pain medication, meaning not prescribed to them, or moving on to heroin. And that's how we got into the situation that we're in today.
Are you seeing this in your office too?
I think every doctor is seeing this. One of the reasons why we wanted to have Holly on tonight is because I don't think anyone really, doesn't know someone who's been affected by this epidemic. As a primary care doctor, I watch it unfold in front of my eyes. I have, grandparents raising their grandchildren. I have, young patients who have passed away. I have middle-aged people, who are afflicted by this. And so I think it's touched almost every fabric of our society. People, from my patients who are employers, who have struggled with their workers who have, struggled with disorders. And so I think it is rampant within our communities. And I was looking at the data, Holly, and Massachusetts is significantly more afflicted by this epidemic than nationwide, right? I mean,
that's correct. In 2016, we breached 2,000 overdose deaths in Massachusetts. And if you look at what they call the hotspot overdose counties, you really have the Cape and Plymouth County and Bristol County, and then Essex County that's way out in western Mass, but those are the worst afflicted areas of Massachusetts. So right here where we practice medicine.
Another reason why I thought it would be great for you to come on and talk about it is, unfortunately still, people don't realize that this is a real disease. Much like heart diseases, cancer disease, there's a family history component to this. There are predisposing factors that can put people at risk for this. And I was hoping you could talk about that. How this, what drives the addiction? Why can someone have their wisdom tooth taken out and get a prescription for, Vicodin and be okay with it, and some people can't? And what happens, and how it becomes,
right.
Who's at risk for addiction?
So certainly people with a strong family history of any kind of substance use disorder are going to be at higher risk. Sometimes we just don't know who's going to be at risk, and we don't know why it happens, but we do know that certain people will experience a certain high or pleasant feeling. And one thing we know about opioids are they're not really great pain relievers, but they're very good at relieving suffering. And so when you think about, you take this pill and suddenly my problems kind of go away, and I don't feel as down or sad or anxious. Those people who react that way are the ones that are highest risk for forming an opioid use disorder. And when you talk to people with opioid use disorders and ask them, what was it like the first time you used opioids? They'll often tell you, I had this sudden sense of ease, or I felt calm for the first time in a long time. And that's actually a risk factor for developing opioid use disorder. Some people have been given opioids and they say, I just threw up and felt horrible and I never want to touch that stuff again. That's protective. Those people chemically don't tolerate these medications as well.
Is anxiety, like you said, like I've read, people who have have, kind of situational anxiety or heightened anxiety, does that kind of put you at risk in terms of like maybe becoming more at risk for addiction as well? Like you're saying, it's make them relax.
It can be. There's certainly a lot of what we call co-occurring disorders. So those are people with certain mental health issues such as depression and anxiety who are self-medicating with substances, whether it be opioids, benzodiazepines, alcohol. And yet there's many people without any mental health disorders who still develop a problem. One thing that is true across the board is it is pretty much universal that every patient who I'm treating in early recovery has some symptoms of anxiety and depression, whether they had this prior to their substance use disorder or not. And that's because of what changes have occurred in the brain with as far as depleting the feel-good neurotransmitters and the hormones and the things that make people feel calm and at ease. Things have changed due to their chronic drug use.
Men versus women in terms of addiction and being at risk and who you treat, are they afflicted differently, or do they have different patterns?
Well, so if we were to talk specifically about opioid use, there is definitely an age group that is higher at this point in time. It's usually the early 20s,
Yeah.
which is when people are most likely to use illicit pain pills. And I would say probably there's more men than women, but women certainly are just as at risk. And then it usually takes about 5 or 6 years, not always, this is just statistics, this is, everybody varies, but what you'll see is the highest incidence of starting to use something such as heroin, or unfortunately now it's really fentanyl, would be in the late 20s.
Okay. Fentanyl. And just for names for people on the street who may or may not know, so opiates are, Oxycontin is a very common, Percocet, people talk about Vicodin. Fentanyl used to be, you can talk about the evolution of fentanyl and what's happened.
Sure. So, yes, so just to be clear, opioids can come in many forms. They can be pill form, which is prescribed or illicitly purchased or just taken. Actually, most people are not taking opioids that they're purchasing on the street. At least 50% of people who are using illicit pill formed, and when I say illicit, I mean non-prescribed, it wasn't meant for them. 50% of those are being obtained from friends or family members. So that's why it's so important that if you have unused and unneeded opioids that were old prescriptions, that they get disposed of properly, because we don't want people going into cabinets and having a habit starting that way.
That's actually just a quick question. How should people get rid of old pain medication? Is that something easy to explain? Because I get that question a lot, and just I wonder, I think it'd be a good topic to kind of brief.
Sure. Well, I know, and I think maybe CVS is one of them, but there are many pharmacies now where you can walk in and dispose of them safely. There's also police stations that will take them back. So, it's pretty controversial as to what you're supposed to do with them if you're not going to leave your house with them. So I'm not going to endorse like flushing them or putting them in cat litter or any of those things. The best, safest way would be to take them to either a fire station, a police station, or even now, everyone probably goes to pharmacies. It's pretty easy to go into one of those pharmacies and dispose of them there.
Great.
Please send along your questions. We have a few general questions, that one from Linda and one from Stephanie, that we will hang on to, and we'll be happy to answer later on in the show. But if you have any specific questions about addiction, opioid use, please feel free to send those along now. And again, you'll see on the screen, and I can share with you that 508-717-8948. Again, 508-717-8948 is our text number. You can text a question to that anonymously if you don't feel comfortable asking in the comment section below. Dr. Podkowa and Dr. Alexandre will do their best to answer your questions. So please send those along. Just to continue the conversation, I'm curious, are there any reasons why particular parts of the state or part of the country are more apt to see higher rates of addiction in opioids?
I think it has to do with availability. For a long time, New England and Massachusetts was more afflicted because we have seaports and the heroin was coming in through the boats, and you wouldn't see that as much as in the Midwest. The Midwest and even the West Coast has much more of a methamphetamine problem, which in my years of treating addiction, which is 14 now, I can honestly say I've had patients who've said they've used crystal meth or something, but I've never had someone who's consistently using it. It's much more opioids here in this area. So I think it has a little bit to do with availability. I wanted to touch on fentanyl. Fentanyl has really become the driving force of why our overdose rate has gone up so highly in the state. Fentanyl is a synthetic, man-made opioid. It's made in a laboratory. Most of the fentanyl in this country is coming in through the U.S. mail from foreign countries where it's been made in a lab. And the reason that fentanyl is so incredibly dangerous and has caused so many deaths is that it's 100 times more powerful than morphine. So the usual person with opioid use disorder who may be using heroin, they know very well how much heroin they need. And I should also be clear that most people, as their disease progresses, they are not using opioids any longer to get high. They're using opioids to try to feel normal and to be able to function and not be ill all day. So they will use enough so that they feel okay and they can get by until they have to use again, because they're constantly in this cycle of going into opioid withdrawal. So what happened was a lot of people were unknowingly getting fentanyl and not heroin. And nobody, the dealer wasn't telling them, hey, this is fentanyl, not heroin. People, it's been enough in the news now, and people have kind of caught on now, but for a lot of times, I saw this a lot in my patients who get urine drug screened. Instead of seeing heroin metabolite, all of a sudden we were seeing fentanyl, and we would talk to our patients about this, and they would say, I didn't know that's what I was using. But the overdose rates went up so high because they would use the usual amount that they would use, and they would overdose. Now we have really scary things like carfentanil, which is 10,000 times more potent than morphine. Its only legal use is as an elephant tranquilizer, and just one tiny little grain of that can kill a person.
What are, in terms of, you're talking about like who's addicted? You know what I mean? Like when, it's like, when should, sometimes it's obvious when someone I think is suffering from addiction, sometimes it's not. It's a little bit different, I think, with alcohol, but so what are the symptoms? If someone's, I think some of my patients sometimes I think are in a bit of denial of whether or not they have a problem with a medication. Certainly when it gets to the extreme cases of seeking and you're not working and affecting your employment, but it starts before then. So red flags for people and actually loved ones and care, of people who may be, kind of suffering or on the brink of an addiction. What do you say?
Well, I'm glad you brought that up, John, because there is a difference between physical dependence and addiction. And we should be very clear about that, because I know there's a lot of patients that may be getting prescribed opioids for chronic pain, and they are taking them appropriately. And pretty much across the board, if you take opioids for any prolonged amount of time at a reasonable dose, and let's say that's anything more than 2 weeks, your body, the brain, that's just part of being human, will form physical dependence. And what I mean by that is, if you stop these medications abruptly, you will have a withdrawal syndrome. You won't feel well, you'll feel achy, anxious, diarrhea. These are the symptoms of opioid withdrawal. Being physically dependent because you take them every day is not the same as being addicted. Being addicted is when patients crave the medication and take them despite knowing that they are causing problems for them. So whether they be social problems, whether it's economic problems because they're spending money on them, whether they're getting them from sources that are other than prescribed. But there are patients with addiction who are still getting them from doctors. Mm-hmm. There are several criteria for having an opioid use disorder, and you really only need a few criteria. There's 11, and you only need 2 to be qualifying as a mild opioid use disorder. So it's pretty easy to fall into that category if you find that a patient is craving, if they are continuing to use despite knowingly that there's problems, if they're using them in physically hazardous situations. Tolerance is one of the criteria, needing more and more, because everybody has, an arthritic patient who may take 2 pills a day of a prescribed opioid for 10 years and they never feel the need to have more than that. Mm-hmm. So that's somebody who hasn't really developed a problem with these medications.
Question from Matthew: what is the best way to get off of methadone?
So I don't know if Matthew's referring to methadone maintenance, which is one of our 3 FDA-approved treatments for opioid use disorder. So the 3 treatments are buprenorphine, which is office-based and has to be prescribed by any kind of a doctor as long as they have a special license or waiver. Methadone maintenance, which is done at a special methadone clinic. If someone is on methadone for opioid use disorder, you can't get that from a regular doctor in an office. You have to go to a clinic. And then the third is an opioid antagonist called naltrexone, which comes in an injectable form that lasts a month or an oral form. So methadone maintenance can be a very good treatment for people, especially if they need daily accountability. Some patients really need someone to lay eyes on them on a daily basis. Yep. To make sure that they're on track with their recovery. Methadone can be difficult. It's a very long-acting medication. It lasts a long time in the body, so the withdrawal from it can take longer. I would say if someone is motivated to come off of methadone, they would really want to talk with their provider and their counselors. All methadone clinics have behavioral therapy and staff that are very well versed in treating addiction and really kind of work on an appropriate taper that works for them. The one thing, when patients want to taper off medication-assisted therapy for opioid use disorder, I always say, sure, if you feel you're at the right point in your life, but we're going to do this step by step. And we can stop and we can go back if we need to, or we can go forward, but it doesn't have to be set in stone the way we're going to do it. So it's really quite individual. But most people on methadone who have come off of it have done it very gradually over time.
Great.
Do you have another question?
No current questions now, but please send them along. I was going to suggest maybe we take a quick 30-second break.
Sure.
Josh, if you don't mind rolling video 1, please.
People actually come up and they're like, I got to hug you. And it's like, this is the first time in X amount of years I've not been in pain. And we get that feedback every single week. Integrating the nurses, integrating physical therapy, that is all part of the treatment strategy, the treatment algorithm. In a matter of weeks, matter of months, they're now able to have the life that they want to live. And that's really more than medicine.
Welcome back. Thank you for joining us tonight. We're talking about a really important subject, which is opioid addiction. We have Dr. Holly Alexandre, who is an addiction specialist, and Dr. John Podkowa, as always, primary care doctor. You're both seeing it in your offices in different ways in general. I know we've talked a little bit about who's more susceptible, but do you see, and we use the term comorbidities or dual diagnosis a lot when it comes to substance abuse and mental health issues. Is there any evidence of shows which comes first as far as the chicken or the egg? Is it normal? Is someone usually using a substance to cover up a behavioral issue problem, or is it usually the drug or alcohol that's causing the behavioral issue? Is there any evidence one way or the other? Does it vary?
So I think that there's definitely, an association between people who are also dealing with depression and anxiety and maybe self-medicating with substances. However, I would say that right now in this day and age, we have an epidemic of young people who aren't necessarily anxious or depressed, who start using pills because their best friend or their boyfriend says, hey, we're going to crush this, we're going to snort this, we're going to go to a party, and we're going to have a great time tonight. And it's kind of what, the pre-partying that used to happen in the old days when people would have a couple drinks before they went out. Now, doing a Percocet is thought to be a great way to get ready to go out and have a good time. And I hear this story time and time again. I see these young people and they say, I just started doing this to have a good time on the weekend. Then I found I really liked it, so I did it the next weekend. And then I did it the next weekend, and by that third weekend, I woke up on Monday and I felt really bad physically. And that's when I found that if I just did a little bit more, I could go to my job or I could go to school and I'd feel okay. And that's where their habit starts. So those patients are not necessarily anxious, depressed people. They're people who are choosing the wrong thing to go out at what they think is going to be a good time, and it backfires.
One thing that I think is important just to spread awareness of, that I've seen with some of my patients, I know you have seen it, is medications like Percocet, Vicodin. They have Tylenol or acetaminophen in them as well, and there people hurt their liver, right, Holly, with this, because they don't realize because there's a limit of how much Tylenol you're supposed to take in a given day, and most people forget that there's actually Tylenol or acetaminophen, the drug that is in these medications, and by taking more and more pills as their dependence builds up, they actually can unintentionally overdose their livers on acetaminophen or Tylenol. I'm not sure if you see that in your practice or the ramifications of that. I've had two patients, who actually needed liver transplants because of an addiction problem that led to an acetaminophen or toxicity. So it's important just to even know what you're taking is
Right.
just really, really important. I mean, it can't be understated enough or overstated enough.
At the opioid forum that was held at the Whaling Museum a few weeks back, you talked a little bit about your experience with maybe overprescribing in just your own experience in life, and then if you can maybe share that story, and then also just kind of talk in general about how big of an issue overprescribing is when it comes to the opioid crisis that we're facing, and what steps we can take as a
Right.
medical
Sure.
society to kind of quell that.
Okay, sure. So first off, I'd like to say that I think, I truly believe as a physician and working in the medical community that doctors never want to harm their patients. But unfortunately, sometimes what we're doing out of convenience for the patient may actually cause harm. And when I say that, I will tell you the anecdotal story that you're referring to. About 3 years ago, my daughter, who was 13 at the time, had a very small day surgery on her foot that resulted in about a 1-inch incision on her foot. And she did fine, and we were going home, and the nurse in the post-operative unit handed me 2 prescriptions. One was for oxycodone, 5 milligrams, and the script was for 50 tablets, 50. The other one was for a benzodiazepine called diazepam, also known as Valium. This was for 5 milligrams, another 50 tablets for my 13-year-old. And I looked right at the nurse, and I was kind of, flabbergasted because I am an addiction doctor, and she was handing me 2 scripts of highly controlled addictive substances for my 13-year-old. And I said, what's the diazepam for? Well, sometimes when we cut into the foot, there's a little muscle spasm, and benzodiazepines like Valium can be used for muscle spasm. But my point was that these were such high numbers. 50. My daughter, I don't even think she took one of either of those prescriptions. We now in the state, since March of 2016, physicians have been working under new laws that were passed by the Massachusetts legislature, as well as Governor Baker signing this law, which doesn't allow this to happen anymore. Now, when a patient is discharged after a surgery, or if you see a patient for a first time, you can only write a prescription for a 7-day supply of opioids. And I think that's great. The other thing that's changed is doctors have to monitor something called the prescription monitoring program, and any patient that fills a controlled substance goes into this monitoring program, and by law we have to check it before we just write any prescriptions for these things. And what we've seen is the amount of over-prescribing has dramatically decreased. And the reason it's important to talk about those scripts is, yes, they got filled, and then what will often happen is my daughter maybe took one of those pills. Now there's 49 left over sitting in a cabinet. And people think, well, you never know when you might need that. Somebody might get a migraine or something. And that's what's so incredibly dangerous, because adolescents might go into there. Family members that you don't know have an opioid use disorder may happen. This is especially true for the elderly. The elderly get robbed by people all the time. So it's very important not to have these medications in our house if they're not being taken and they're not being kept secured.
So, and just in general, what would you tell a patient who, if for whatever reason their doctor prescribes an opioid to them or to their child that they don't think is necessary? What's your advice to those folks?
I mean, I think you should. I think you should have a healthy respect of any opiate medication or any what's called a controlled medication, whether it's whether it's a Valium or an Ativan or these type of medications. But irrespective of any medication, I think you're being given by your doctor. I mean, I wholeheartedly agree with Holly that we are in a profession of helping and healing people, and we act in their best interest. But you should always have a kind of healthy discussion, I think, with your doctor who's treating you about what you're taking and why and the risks and benefits. I think it's an important part of treating high blood pressure, diabetes, pain, and infections. That's kind of my take on it. Would you agree?
Yeah, definitely. I think that one of the most important things in the doctor-patient relationship is communication, and taking that extra minute or 2 minutes it takes to say, and like this can happen even when you're seeing somebody for cold symptoms and they automatically feel like maybe they need an antibiotic.
Yeah.
And when you say, hey, these are the risks of antibiotics, and I'm not opposed to giving you one if we decide you really need one, but let's look at the risk benefits of this, and what if we put this off and you call me back in 3 days? Those type of conversations need to happen, and they need to happen around all medications, including especially opioids. There are many great ways to treat pain. We know that non-steroidal anti-inflammatories such as ibuprofen are excellent if someone is appropriate for them. We know that Tylenol works. We know that for people with chronic pain, things like alternative therapies such as acupuncture are very helpful, massage therapy, physical therapy, chiropractic care. We know that icing helps. We know that exercise helps. So there's so many different ways that doctors really are now, I think, needing to approach those other modalities, and we as a country really need to put our efforts into how to treat chronic pain in a way other than just sending patients away with a prescription for something that may not actually help them in the long run and may harm them.
Paradoxically and almost cruelly in a way, as time and studies have looked at this, opiate medications which were prescribed for pain actually change our body's perception of pain. It actually can make you more sensitive to pain, I think, Holly. I mean, so it's almost like a double-edged sword. So not only are you not really getting great pain relief from this medication and a host of symptoms, the constipation, the sweating, and a variety of things, that actually you're becoming hypersensitive to pain to begin with. So medications that work really well for people not on opiate therapy, like ibuprofen or Aleve or naproxen, like you just mentioned, don't seem that effective right away. But as you get off of them, and my patients who a lot of them do want to get off of them, or are afraid because of the pain, but actually a lot of times their pain gets better as they can transition onto other medications. And we have a really good, at Southcoast, we're really fortunate to have a great pain management center that we collaborate with on a regular basis, who are, again, another specialty like Holly, but their specialty is pain, and do it safely and effectively, which is just a really nice resource to have for patients.
So this is a really great conversation, and we continue to welcome any of your questions about opioids and addiction. But I think we can shift gears now and get to some of the more general questions that have been sent in. The first is from Linda, and she's asking about cholesterol. She said she's on medication, but the numbers aren't going down. What other suggestions would you have for her?
Great question, Linda. Super common in primary care. I wouldn't, kind of an hour doesn't go by that we're not usually talking about cholesterol. Without knowing you, it's hard to say, but it is, depending on how high your numbers are and what type of medication you're on. Some of the more common ones are, used to be Lipitor or Crestor or Zocor. They're generic now, so they have other names. Perhaps the dose might not be strong enough. Maybe, switch to a different type of medication. I'm not sure if she's changed her diet yet or not.
I'd really emphasize diet.
Yes.
Really moving towards a plant-based diet as much as possible.
That's where Holly and I get along.
So, I mean, it's hard to find someone unless they have a real familial component, and some people do. Some people inherit their high cholesterol, but when people really try to eat as much plant-based as possible, you see those numbers go down.
I try to tell my patients, I've worked on this and spoken to some friends who are kind of experts in lipids, but to give them like a simple walk away, and it's cheese. Basically, other than taste, I don't think there's any redeeming quality in cheese. You know what I mean? I really think if people eliminate, and I talk to them, how much cheese is in your diet? And I think just by cutting back or eliminating or curtailing cheese, I mean, people make a difference. And I love pizza.
Tastes so good, though.
It does, but but you're right. We, vegetarian, plant-based diet, I think is really a home run in terms of
regular
all
exercise is, helps things like triglycerides to go down and HDL to go up, which is your good cholesterol that you want to be higher.
Yeah.
So I had to Google this one. How do you get rid of xanthelasma? So you close there. It's the yellowing around the eyes.
Yeah, those are cholesterol deposits.
Yep.
Those also can be hereditary.
Mm-hmm.
So as far as how to get rid of them once you get them, is that what the question is?
Yeah, it's the question was from Stephanie. She was saying, how do you get rid of them at home? So I'm guessing, is there a way to...
Actually, I can't speak to that, I don't think, unfortunately.
I don't know the answer to that either, other than, if there is a procedure, I think you would want an ophthalmologist to be working in that area.
Well.
Yeah.
Because anything around the eyes,
Yes.
ophthalmologist, that's
Yeah.
your eye
I mean, I think you
surgeon.
want to figure out what's driving and why, making sure your cholesterol is in control.
Right.
But I don't know if by driving down your cholesterol you reverse that process and they go away. That would be my question for the ophthalmologist.
And so I'll preface, before I ask the next question, I'll just preface that there are some of these questions that are coming in are super specific, and it's really hard to ask the doctors to answer specific questions without them being a patient and really knowing a lot of your back history. So I apologize if you've asked a very specific question. I'm going to kind of generalize it a bit just so that it's more applicable to everyone watching, and so that we're not diving too far into, what would be your personal health history here. So one of the questions that we got in through, and again, and I'll also preface that while you are primary care doctors and handle the scope of general medicine, there are some very specific fields that you don't treat or whatnot. In those cases, we're happy to kind of give you some guidance, as we mentioned with ophthalmologists. For an eye, that's who you should go speak to when. It's specific to a body part. So I preface all that to ask the question, estrogen pills for transgender people. Is that something that you're dealing with in your office if someone comes to you and they're looking to potentially change their sexual identity? If someone comes in...
So there's wonderful specialists that treat people as they transition, and I have several patients, but they do see specific endocrinologists, which are doctors that deal with things like hormones. I think it's very important that that care is done usually because there are things that need to be monitored in their blood work. There may be some risks to these medications. Also, that specialist knows very well how to alter doses so that the desired changes occur. And I think the primary care role is to be aware and understand what our patients' needs are and to be able to get them to the specialists that they need to help care for them and to support them in that transition. But as far as I don't personally manage the medications.
Nor do I.
Hair loss question. Is that something that you guys would deal with if someone came in and was considering a hair loss procedure? I know there are specialists, you hear it on the radio all the time,
Sure.
of hair replacement specialists.
I mean, I think,
but general thoughts on hair replacement, do you think it works in your experience?
so hair loss is a very common complaint. I see it, you probably see it a lot, also men and women.
And women, one thing to understand is that women lose hair like men lose hair, but it's socially acceptable for a man to have lost his hair. And women, it's a huge concern to them when they lose hair. And often they think something's medically wrong with them, when really it's a normal part of their aging process. Hereditary, it's very hereditary.
I was just going to say, it's another important, so we've talked about on the show before the importance of family history and knowing there are some very simple things, knowing your family history. So if you do have a family history of hair loss, it can be hereditary. Other things can cause hair loss as well, right? Like stress can certainly actually cause hair loss. Thyroid disorders can cause hair loss.
It's super common after women give birth for them to lose hair. Just that process of giving birth is such a stressful event on the body, even though it's a normal, natural event, that women often will lose hair. There is a difference between generalized hair loss and thinning and patches of baldness. That's and when those patches of baldness occur, we often send patients to dermatologists because there are specific treatments such as steroid injections into that area or creams that they use.
Yes.
So if as a patient I came to you and said, "Hey, doc, I'm thinking about getting hair transplant or hair replacement," would you say what would be your advice as far as would you is there someone in the system that would see them specifically, or is it really do your homework and then maybe go talk to a hair replacement
I think we
specialist?
find out if nothing's driving it. There are like topical therapies I usually recommend first because it's a bit more dramatic. I think any surgery you try to do everything you can to do before you have to have the surgery if there's anything involved.
Right, but I think of it as kind of like, what's the risk benefit?
Yes.
So if their benefit, because they're going to feel a lot better about themselves, and if it's a low risk procedure, and I'm pretty sure it's a low risk procedure, so if that low risk is much lower than the benefit that they're going to gain from it, then go for it.
From Caitlin, any tips on managing hypothyroidism? She's had it for close to 10 years and still not under control.
All right.
So another pretty common, I guess first is obviously I hope she's seeing a doctor and figuring out what drove her thyroid to become underactive. That's the first probably I would say, right, Holly? Like what's causing her thyroid to not perform like it should. And then once that's addressed, if it's an autoimmune process, there are medications there are that you could go on, that many people go on. There are specialists, endocrinologists, like you mentioned earlier, or Holly did, about who specializes in it as well. So if it's a difficult thyroid, you may want to consider getting a specialist second opinion.
And also probably to understand that sometimes people's thyroid studies, meaning their laboratory values, fall within what the lab is calling a normal range. But if you speak to a specialist on thyroid, they actually have kind of a tighter range that they prefer. And some patients who are hypothyroid don't feel well, even though their TSH, which is our lab value that we use, might look normal. Sometimes they need to have their medication tweaked. One thing that's very important is to take your medication medication first thing in the morning on an empty stomach. Some people are very, thyroid, things can cause absorption of levothyroxine, which is the most common medication, not to be absorbed well. Anything with calcium, so if you're drinking orange juice fortified with calcium, that could be a problem. So there's a lot of different ways to...
In my experience, I'm glad you said that. I think that is one of the first things to look at. That are they taking their medication at the right time without anything else around it that's interfering with absorption? Because that's often the most common cause of not getting your thyroid levels to where they need to be. If medication is the right answer for the why your thyroid's underactive.
It's also, for some people, there's a lot of people who thyroid is their only medical problem and it's the only pill they take every day, and it's hard to remember. It's hard to remember to take a medication every day. So setting a reminder on your phone, using a pill box, all of these are kind of good mechanisms for that. I speak from experience. I have 2 out of 3 of my children are hypothyroid, diagnosed at like age 6 and 10. And my son, who's now 13, I have been struggling with that kid remembering his thyroid pill. I got him a pill box, remembering. Now he has a smartphone, his iPhone. He sets a reminder, and he said to me, "Mom, ever since I set my reminder, I haven't missed 1 dose." So great reason to let your teenager have a smartphone.
I think the pill box is a great example. I take a pill daily, and the way I remember is I put it in a pill box, and I also started taking other vitamins as well. So I take a fish oil vitamin and a multivitamin, and I take them together. I put them in the same thing together. And just so the thought, so you get in the routine of having several pills, it's harder to forget. And when you have the pill box, you can kind of go back and say, did I forget to take it today? Because usually in the same day, you can't remember whether you did or not, and you go back to the pill box, and if they're marked by the day, then you're not doubling up.
Sometimes you can't remember 1 hour later.
Yeah.
Yes.
So we have actually two questions that came in that go back to addiction.
Great.
One of them is
I love talking about that.
one of them is a compound question here. So I'll ask the first part is, do you see any overlap between overeating and other addictive behaviors?
So food addiction, although the Academy of Addiction Disorders, they don't recognize, like the DSM-5, which is what we as doctors use as diagnoses, they don't consider, there's not an official food addiction disorder, but we clearly know that there are people who use food and often are overeating or treating anxiety disorders and depression. So is there an overlap? Well, I can say that sometimes I most commonly see people who are in recovery who will then go to another thing. So they have their opioid use or their alcohol use under control, and so they kind of transfer some of that addiction to something else, and food may be one of them. I think as human beings, we all have some tendency to be a little addicted to something, and really the more fortunate ones may be a little more addicted to exercise or whatever it may be, but I think there's a little bit of that there in everybody, and how it presents itself is different among people.
And you may have kind of answered this already, and I should add that this question comes from Lori, who's a friend of the show. Hi, Lori.
Hi, Lori.
So she's... the treatments overlap. So I guess is there a connection with alcohol use and overeating as well, or does that kind of fall kind of into the answer that you just gave?
So once again, every individual is different.
Yeah.
A lot of times with alcohol use disorder, people actually aren't eating well, and they're malnourished because they drink so much alcohol that they don't eat. And so you will often find people who may be overweight, but that's mostly alcohol calories, and they're actually not nutritionally sound. But some people in recovery will move on to and overeat, but that's why when people are in recovery from substances, you really want to focus not on just being abstinent from the drug or alcohol, but having kind of this whole wellness, and part of their treatment is self-care, whether that be starting an exercise regimen, eating well, developing better relationships, working on their career or their schooling, like all the things that make us as human beings feel good about ourselves.
Actually, I have a question for Holly before I
Absolutely.
if that's okay with
Please.
you. I have her. So, treatment for opiate addiction.
Yes.
3 major ones.
Yes.
Methadone, naltrexone, and commonly Suboxone therapy, buprenorphine. Who's appropriate for, what type of person, and how do people get started? Maybe
Sure.
because I think just
Right.
there's probably a lot of questions and.
So I'm glad you asked that. One thing I would like to emphasize is that this is a chronic brain disease and it needs to be treated. So often family or even the patients themselves, they think of it, there's so much stigma around it. They think I am just, morally weak, I'm a weak person, I can't stop using these drugs. What they have to understand is that's not the case at all. This is not a character flaw. This is a brain disease. When someone uses opioids over and over and over again, and the addicted brain starts changing, it rewires itself. It does something called upregulation of opioid receptors. And what that means is we all have opioid receptors in the pleasure center of our brain, and not necessarily opioids bind there, but things that, when things that make us feel good, like exercising, eating a good meal, anything that, having a nice relationship, those type of things. So those all make us feel good. That's happening in our pleasure center of our brain. These patients have more of those receptors, and so they feel depleted, like they don't have enough of that, and so they crave, they need more and more. Patients, everyone kind of thinks, and there's always this big push for there's not enough beds, there's not enough inpatient beds, we don't have, people can't access treatment fast enough. But inpatient beds, and when I talk about that, I'm talking about an inpatient detoxification facility where someone would go and have a medically managed, supervised detoxification from their drug or alcohol. They're being given medication to help them with their withdrawal symptoms. Insurances may cover this for 3 to 5 days, 7 days if you're lucky and you can stretch it out, and then they get discharged home. And universally, pretty much all the time, there are rare exceptions, so someone might say, I know someone that did okay after one detox day, but I will tell you time and time again, people get out, and without the proper outpatient follow-up and proper outpatient care, they will relapse. Because you don't take a diabetic and put them inside a hospital for 5 days and then get out and their diabetes is cured. It's the same way with opioid addiction. So when a patient comes to me, the 2 things I can offer would be buprenorphine or naltrexone. Methadone maintenance is a full mu opioid agonist at the receptor. And what that means is it works similar to all the other opioids. There's no blocker in there. That can only be done at a special methadone clinic. The things I can offer in my office are buprenorphine, which is an agonist-antagonist. And what that means is when patients take this medication, it has a ceiling effect. They don't develop tolerance to it. I've never had a patient overdose on it. They tell me time and time again, I feel normal on this. They don't feel high on this. They don't feel sedated on this. They can function. They get their lives back together. They go to school. They buy houses. They do their jobs. They parent their children. The other part of that medication is there's a blocker in that because the buprenorphine has a higher affinity, meaning it binds stronger to that opioid receptor. So if someone has a moment of weakness and says, I just want to see what will happen if I just go try a little heroin or snort a oxycodone, it blocks it. They get no effect. And so then they're in my office the next week. Their urine drug screen has either shown that they've done that or they admit that they do that and they say, yeah, that was pointless. So this is why this medication can help so many people. Are they physically dependent on it? Yes. So if they miss their dose, they don't come back to get their refill, will they have opioid withdrawal? Yes. But we said earlier in the show that being physically dependent is not the same as being addicted.
Yep.
So these patients are not craving more. They're not out looking for more. They are being treated like one would treat anyone else with a chronic disease.
Like high blood pressure,
Yes.
diabetes, yeah, I think it's an important
So
point.
if a patient comes to me and they just used an opioid that morning or that night or the night before, I can assess them and prescribe this medication and get them started on it. That's a medication that they need to see me regularly for.
Once a week?
Initially, my program is once a week. People in early recovery need a lot of help and support, so I will see them weekly. As people progress and do well, we spread those appointments out.
And when people see you, they don't just see you, talk to you, get their medication. There's a whole team of your office, which
So
is
I
really
have
great,
a
right?
wonderful team in my
Yeah.
office. It's a great place, I will say. I
is.
have the best team. But in my office, I have a group, from the moment people call, they will be assessed over the telephone by someone who's knowledgeable about opioid use disorders. My staff from the front check-in people are very good at understanding the disease, and they're very flexible and very discreet and confidential, as most doctors' offices are, but people worry about that. The other thing people like about my office is it's a regular primary care office, so they don't feel stigmatized that they're in a place that's different. They're very comfortable there because they know the people and the same staff. The medical assistants check people in. We do urine drug screens. That is standard of care and routine to do that on people who are in recovery. And then they're assessed for, by the medical staff. How are you doing? Any side effects? Have you had any problems this week or this month or whatever it may be? And then what I have that's great is right there integrated into my office. I have a certified drug and alcohol counselor, and she sees my patients at every single visit. And those visits sometimes can be very brief, or they may be much more entailed and longer, depending on the needs of the patient. This allows patients to have the behavioral health component that is necessary when they're getting Suboxone or buprenorphine, but it also enables them to have a resource. She's their, the person that they call when they need anything with regards to their addiction disorder, and also she's a great resource for knowing what else is out there in the community, because most patients need more than just that visit with us. What we provide, which we call medication-assisted treatment, is incredibly important, but patients also need the behavioral health component. They need to work on what are their habits, what are their triggers, why do they turn to the drug, how else can they cope? And these things go hand in hand, and the most successful patients in their recovery are the ones that will engage in both. One quick other thing about Suboxone or buprenorphine. People say, I don't want to just be dependent on something else. It's just another habit. It's another something I'll have to get off of. And, this medication saves lives. And, to me, it's like saying, somebody who's glucose toxic, you're not going to give them insulin.
Or have blood pressure. You're not going to control
you're not
your
going
own
to treat that, because if they just go run 6 miles a day and lose 50 pounds, they'll get rid of their high blood pressure.
No.
It's not very reasonable. The next medication, you want me to go on to the next medication?
Do you have a question?
We do have a question. Yeah, we have a couple, and we're actually running it down out of time. We have a little less than 10 minutes to go here. So,
It's a good thing.
the question is from Trisha, and she's wondering that what resources are there for someone who might have an opioid problem but is afraid to talk to their physician? So if you don't want to go to your physician for help,
Sure.
well, what else could you do?
Okay. So, first of all, I would hope that they could go to their, I see this time and time again. Patients are really scared to talk to their doctors, but, doctors are there to help you. And so I would hope that they could talk to them. But let's say that person wanted to do a treatment such as buprenorphine, like I prescribe. You can go on websites to look where where providers are in your area. One of them is SAMHSA's website, samsha.gov. And that can tell you where people are. We didn't get to naltrexone, which is the opiate blocker, but I think that also the Vivitrol website might tell you where people do that as well. So there's online resources to find out where providers are in your area.
Great. I know that neither one of you are family medicine or pediatric docs, but I imagine. Oh, you are family medicine. Okay.
Holly's family
So
medicine.
sorry. Okay, so this is a question for you. So autism. And I know that's not just solely a pediatric issue, but obviously it's detected mostly in children, and so the question is medications for autism, or just generally how do you deal with a patient who has autism? What kind of treatments are you providing or guidance are you giving them?
Okay, so I think one thing we have to understand is that autism is really a spectrum of disorders. And so there can be so many different, I guess you would say, severity levels. Some people may have, mild forms with certain, things that are dysfunctional, or you can have someone with more severe forms who maybe is not verbal. So the best thing I think would be assessing what the patient's needs are and also making the proper diagnosis. There's excellent behavioral and developmental pediatric specialists. So it is standard of care for all pediatric providers, whether they're a pediatrician or a family doctor, is when we're seeing children in those early years and we're doing child visits on them, you want to engage the parents in questions about the development of their children and are the developmental milestones being met. We have specific questionnaires we can ask them, and you ask about how is the patient socializing and different things we ask. And if you identify something early, it never hurts to get an evaluation the earliest as possible. And that's when you can then get any extra care that you need.
Switching gears, best test for cortisol.
So a bit of a nuanced question, but usually it's tested in the morning early. It's a blood test that your doctor can order.
Okay, and that was the second part. Was it blood or saliva? So it's a blood test.
Well, I'll be honest. I'm not an endocrinologist, but
I think in general it's an 8 a.m. blood test.
It's a blood test, yeah.
Okay. We talked about this 2 weeks ago when Amanda was on, and your memory, I'm sure, is better than mine. So, and just from your own experience, but just some steps to deal with anxiety, depression, for people who aren't willing to get help. So I guess this is advice to a family member of someone with anxiety, depression who won't get help. What would what would you advise?
I mean, there's a host of things. I think, and Holly can speak to this as well, but I think if they are able to, one of the best prescriptions for people who are down or depressed, I think, is again exercise, walking, movement, getting out. I think I think there's really good evidence that kind of being active helps improve mood. I think also making sure you're getting enough sleep is really important to it as well. I think if they're willing, I don't know if maybe they don't want medication, but if they have a counselor, if they'd be willing to talk to someone, like in terms of a counselor, it's really great resources as well. I mean, Holly,
is the question more specifically if your family member is depressed or anxious and won't get help? What do you do?
Yeah.
I think just starting with, once again, there's a lot of stigma around depression and anxiety, and people don't want to admit that they may be suffering from this very common illness. If you could get that person just to go for a routine doctor visit even, and talk about some of the, a lot of times people with these symptoms, they don't all come out as what we classically think of as depression and anxiety. Sometimes they come out what we call as somatic symptoms. So people may have a lot of stomach upset, or they might have chest pain, or other symptoms that are really attributed to depression or anxiety. And so the first step I would be is saying is, can you just get to your primary care doctor?
And then we've talked a lot about endocrinologists today, and so someone's wondering,
That's your next
does
step.
Southcoast have a good one? Who do you refer to in the system?
So we have several good endocrinologists in the Fall River and in the Portsmouth area. Dr. Charles Isle, Dr. Anderson, and Dr. Beatrice de Moranville are fantastic to work with. So we're really fortunate.
And for any of those docs, and just to find out more about what we have for endocrinologists in the system, you can go to southcoast.org. There's a simple search tool there where you can search for doctors. You can search by specialty. So if you just, again, go to southcoast.org, search for endocrinologist. When you go to find a doc, and it'll bring up everyone who we have in the system who specializes in that, and you can see where they're located, find the doctor that's close enough and works best for where you live. So we're winding down now. We're past the 8 o'clock hour. Any final thoughts from either of you on addiction?
I
on
personally want to thank
substance?
Holly for coming on and one, just being such a tremendous resource for my patients that see you, and for the other patients in the community, that the work you're doing as a primary care doctor, two as an addiction specialist, and also coming to thank you for teaching us more about it.
Thank you. My final thoughts would be, if you are someone with an opioid use disorder, or you have a loved one, family member, friend, just understand that there's treatment there. It's a treatable disease, and seeking out that care is the first step.
I also want to say, just in terms of access to Holly's office, it's on our website as well, southcoast.org. You can look her up. And I think for all the people who watch, if you thought someone might benefit from the show, please share it and pass it along, because it's a really good message, I think, about treating opiate dependency and addiction, that it is, like Holly said, an extremely treatable disease, an important disease, and we have good therapies for it that work, that are
Absolutely.
safe.
Yeah, this video will live in perpetuity for as far as I know on New Bedford Guide's Facebook page. So you can always share. You can always add additional comments. We try to monitor and track any new comments that come through. So if you have any additional questions, feel free to put them in the comment section, and we'll try to get to them and try to pass them along to Dr. Alexandre or Dr. Podkowa. Also, if you have any thoughts for shows in the future, any subjects that you'd like to talk to with Dr. Podkowa and a guest, please send them along. You can do that through, most effective way would be to do it through the phone number that we've been showing today. You can text that to us. We'll have it. We'll start a queue of subjects that have been requested, and if we get a lot of asks for a particular subject, or if it's a really good idea, we can certainly bring someone on as a guest, to hit on that subject. So next week we will be back at 7 o'clock on Wednesday with a guest from maternity. I believe we'll have two guests from maternity. So Dr. Podkowa, you'll be flying solo, hosting that one with our two friends from maternity. Again, if you know anyone who's pregnant, anyone who's thinking about getting pregnant, I think it'd be a great opportunity to ask any questions that you or they might have. And then we're going to take the following week off in between between Christmas and New Year's, and then we'll be back after the first of the year. So please tune in next week. And again, if you have any questions in the meantime, please send them along. Have a great night. Take care.
Good night.
Good night.